It's my pleasure to introduce Dr. Elissa Downs and Dr. Melena Bellin, who are going to talk about chronic pancreatitis in children. I think many of you encounter these children on the wards after they've had their islet transplant. I'm not sure how aware you are that this is considered the center for islet transplantation of children, and that Dr. Bellin is considered the world expert in this area. Of course, it's a team effort, and the islet transplant is just the end of a long journey. So they are going to tell you all about it.
All right, so I'm going to get us started, and we're going to start kind of back at the beginning. But first, just our obligatory disclosure slide. So take a second, okay? All right, here are our brief objectives for the day. So today, Dr. Bellin and I are going to talk to you about clinical and research updates on acute and chronic pancreatitis. So our objectives are just for you to become more familiar with modalities used to diagnose pancreatitis, understand the risk factors for pediatric chronic pancreatitis, and then understand outcomes of the management of chronic pancreatitis. Like Dr. Moran noted, that we are one of the top centers that perform the TPIT procedure. Okay, so here's our dynamic organ of interest today, just to orient yourself to the anatomy of the pancreas with its both exocrine and endocrine functions, which is why you get both of us today. Okay. Kind of a brief start to give you an introduction. Research into pediatric pancreatitis over the last 10 years has been really spearheaded and organized by a group called INSPIRE. And this stands for the International Study Group of Pediatric Pancreatitis in Search for a Cure. This group consists of gastroenterologists, endocrinologists, and radiologists with over 20 center sites in the U.S., Canada, Israel, and Australia, including here at the U of M. So this is an NIH-funded project, and the first cohort enrolled over 560 children at these 20 different centers. Overall, they've been very prolific in their research in an effort to standardize definitions of disease, kind of provide recommendations for management, and then publish the latest research in the field. Their goals are a few. So one is just to collect information from acute recurrent pancreatitis, here abbreviated as ARP, and then chronic pancreatitis, abbreviated as CP, and collect information from these cases over time to just better understand the disease. They want to create a network of pediatric centers to perform these clinical studies. And then their ultimate goal is to just develop better therapies over time to improve the lives of children with pancreatitis. And there is a second cohort that is currently in progress. Okay, so some of you might be aware this week is Public Health Week, so we'll talk just a little bit about scope of disease and give you sort of an epidemiologic overview. So this is just a first graph here looking at kind of the last 3 decades or so at the incidence of both acute and chronic pancreatitis over time. This is a study from a Polish group that has one of the largest cohorts of patients with chronic pancreatitis. And as they've been looking at the darker line, they've kind of seen a change from 1988 to 2015 of about a 15-fold increase in the incidence of chronic pancreatitis, and then about a 3-fold increase just over the last 2 decades in their acute pancreatitis cases that they've been tracking. All right, and then this next study is just a study from CHOP, and so it's looking at their inpatient admissions from early 90s to early 2000s. And you can see that the light gray is just looking at first admissions for acute pancreatitis, and then the kind of the black or the dark gray is looking at all admissions for acute pancreatitis over time. And you can kind of see from a low in the early 90s to a definite peak in the early 2000s. They had a caveat that this is looking at just inpatient admissions, and so as our awareness and our knowledge of how to manage these diseases get better, it could be missing some cases that were more mild and discharged from the ED. And in both of those studies, they came to an impression that this increase in incidence over time was likely due to increased awareness of the subtleties of how to diagnose pancreatitis in different age groups, and that this was likely accounting for these changes that we've been seeing. So not that there's been a dramatic increase in how often pancreatitis is happening, but just so we're better aware of it. So if we've established that there has been an increase in incidence over the last few decades, and we think that this is largely due to increased awareness, that has a few different ramifications. So one is that the more aware people are of that this is happening, the more that they will actually test for it. So this figure is just from a 2010 study looking at the number of amylase and lipase measurements that have been done over time. So you can definitely see that it has been dramatically increased over this time period. The other thing to think about is that there's been a rising incidence in obesity over the last few decades, and with obesity comes dyslipidemia and primarily biliary disease in the form of gallstones. And so that will also account for an increased incidence in this type of disease. So as we're looking at numbers overall, there's sort of a broad range from different cohorts about where exactly this stands, but we're sort of looking at from the pediatric standpoint anywhere from about 3 to 13 per 100,000 per year. And just a very broad range in the adult world of anywhere up to about 5 to 60, but different studies may also report that being a bit higher. This bottom graph is from a 2018 study where it had been looking at incidence from 2007 to 2014. And I think one of the encouraging trends is that we've seen it sort of stabilize over time. And they were seeing a relatively flat line in the incidence in pediatric cases, so those dark black lines on the bottom, with most recent incidence being about 12.3 per 100,000 per year. So the burden of acute pancreatitis is also quite large. And so as we're looking at that incidence, a lot of that does translate into inpatient hospital admissions. From the same study that I had just referenced, this one is looking at taking that incidence and translating it into hospital admissions. So we're seeing that somewhere in a range of 6 to 7 per 100,000 per year. Whereas you can see the adults in the gray are somewhere up at 60. So hospital admissions, I think, are two different ways that we can end up looking at that. So one is looking at length of stay overall, and then we'll also look at cost. So you can see length of stay, this is from a 2018 article, is the highest in the group that's actually under 5. So we're looking at an average of almost 3.5 days inpatient. That does decrease a little bit in the next group, the 5 to 14-year-olds, with a need of about 2.1 days. But then it does increase again in the greater than 14-year-olds, almost up to 3 days of inpatient admission. And so then as we're looking at cost, you can see that the median cost per day in the ICU, and this is from 2017 data, is about $3,000 compared to an inpatient stay on the general pediatric floor, which is about $2,200. And if we're looking at a length of stay median of about 13 days in the ICU, that ends up being about $40,000 for some of the more complex or severe cases of pancreatitis. Okay. This should be something that's quite familiar to all of you, just a quick review of what we think of as underlying risk factors for pancreatitis. A lot of these are going to be more relevant to acute pancreatitis, but they do set the stage for more chronic pancreatitis later on. So as we're thinking about it, I've given you some percentages in the bold, and the bold ones are going to be the more common risk factors identified. So mechanical causes of pancreatitis are going to be identified in about 30% of cases, and that's going to be mostly things like gallstones, but early on we might see issues with duodenal obstruction. Toxic factors are almost negligible in younger kids, but do become greater as kids progress into teenagehood and then as in adulthood. So things like alcohol and smoking. There's a few handful of metabolic factors. And then drugs become pretty relevant, especially in the population of kids that we see that are going to be on chemotherapeutics, immunosuppressive agents for autoimmune disease or inflammatory bowel disease, or even starting into the teenage years, hormonal contraception. Infection rounds up about 10%, and you can see there's a variety of disease. It's really hard to sort of pinpoint if an infection is related, unless you have a really strong clinical history and there's no great other explanation. Trauma is an also important one to consider. So this is going to be any sort of abdominal injury, non-accidental trauma, or even some of the things that we do to kids in more iatrogenic trauma. And there's a handful of other categories thinking about congenital, vascular or systemic disease, and then sort of a miscellaneous group. But I think most relevant to the population of kids that we see here are going to comprise the genetic etiologies. The 10% here is what we see more in acute pancreatitis. Okay, here's just another way to look at this. This is from a 2017 review. And so on the left, you just see a pie chart of the different ways that this is broken down, and similar numbers. So biliary disease is about 30%, idiopathic is about 20%, and the medication is kind of around 25%. And then sort of in the middle, it's just breaking it down per age group. So you can see that in the older age groups, more of the idiopathic starts to rise up, whereas in the young age group, it's more of the inborn errors of metabolism. But across all groups, we can see biliary causes. Okay. So how does an etiology lead to an injury? This is just sort of a theory of how this can occur. So you can either start at having duct obstruction issues with the pathway starting on the left, or acinar cell injury with the pathway starting on the right. And either pathway that you can take ends up causing injury, proteolysis, fat necrosis, sometimes hemorrhage, and inflammation to give you that acute process of pancreatitis. So now that we've established how it could happen, we need to figure out how we actually diagnose it. The criteria that I've put up here are from that INSPIRE group. Again, really just a standardized definitions of disease so that we're all working on sort of the same platform. So as we're looking at the diagnosis of acute pancreatitis, we really do need 2 of the 3 criteria. So we're looking just at that top row there. So we really do need some sort of abdominal pain suggestive of or compatible with acute pancreatitis. And just to keep in mind that that may be more vague in younger kids. It may just look like irritability or pain or vomiting. It may not be classic epigastric pain radiating to the back or anything like that. We do need a serum amylase and or lipase greater than 3 times the upper limit of normal. There are some caveats to some of that testing, but we won't get into that today. And then the third thing, some sort of imaging findings that are characteristic of, again, or compatible with acute pancreatitis. So most often we can use that through ultrasound imaging. It's recommended as the first line modality. And you're looking for things like a diffusely enlarged gland, a gland that looks hyperechoic. There might be peripancreatic fluid. You may see gallstones. If, as often happens, the pancreas is obscured by overlying bile gas and you can't quite get a good view of it. If you have suggestive abdominal pain and if you have your laboratory abnormalities, you don't necessarily still need to pursue additional imaging. And then we'll get to the diagnosis of acute recurrence and chronic pancreatitis later. Okay. So as we're looking at the kids that are diagnosed with pancreatitis, it's important to note that up to 25% of them, they have a form of severe disease. And this is looking at either transient or a more permanent organ dysfunction. And then up to 10% of these kids end up having ICU care for closer monitoring. There are a few predictive models, largely more established in adults, to determine severity of disease. So I'm sure some of you are familiar with some of these criteria. And there have been some researchers that have looked at predicting severity in pediatric cases, but it's a little less clear on if these models that they've put out really have the ability to predict. So some have looked at lipase, albumin, and white cell count within the first 24 hours. Others have looked at lipase elevation alone. But really you're just looking for, in those first 24 hours, how are they responding? And are we having signs of complications? Overall, though, good news is mortality is pretty rare in the pediatric age group. From a 2018 study across their different age groups that they looked at, they estimated mortality at 0.1 to 0.2%, whereas this 2011 study was reported just sort of general mortality less than 5%, looking at more severe cases of pancreatitis. Okay, so swinging into management. These recommendations are going to be taken from the, I even misspelled our acronym, shoot. The North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. They put out a report in 2018 with these guidelines. So first to think about, and most importantly, is fluid resuscitation. This is going to be the most critical thing to help prevent some of the complications. And so that's kind of debated in the pediatric world. But whereas in the adult world, they kind of feel a little bit more solid in their recommendations. So from the International Association of Pancreatitis and then the American Pancreatitis Association, they pretty strongly come down on the side of lactated ringers. Although to note that some of these initial studies were done in very small populations, but felt that with this fluid choice, within the first 24 hours, they were seeing decreased evidence of a SIRS response and decreased CRP. As our group was looking at it, they really just didn't feel like there was enough data to support this use in children, so you could certainly consider it, but otherwise, dextrose and normal saline is usually well tolerated. As we're thinking about how to aggressively fluid resuscitate these kids, it's usually starting with a bolus and then thinking about 1.5 to 2 times maintenance, especially over that first 24 hours with some really close monitoring. So that monitoring includes cardiovascular monitoring. And early and persistent tachycardia can definitely predict some of the severity and may let you know if you're underestimating your fluid requirements. Respiratory complications may include things like pleural effusions, pneumonia, or acute respiratory distress syndrome. And then as we're looking at the kidneys, acute kidney injury is definitely a complication. So BUN and creatinine should be monitored pretty closely, and you should be titrating your fluids to get adequate and appropriate urine output. Pain management is also sort of a hot topic in latest research. And as the NASPGHAN group was looking at this, they definitely thought that overall there'd been sort of limited studies at that time on what we felt was the optimal route of pain management in acute pancreatitis. But I think everyone felt really comfortable recommending IV opioids if patients weren't initially responding to acetaminophen or NSAIDs. One interesting study that came out just last year, looking at patients that presented with acute pancreatitis in the emergency department, as they were looking at things, they noted if a patient was first given a non-opioid, they required less total doses of analgesia over time and had better pain control early on. So I think as you're looking at that graph on the bottom right, you can see in the light gray, looking at total doses, those that got a non-opioid first required fewer total doses over time, whereas if they started with an opioid first, they tended to need more additional doses. So just something to sort of think about as we're looking forward at how to decide what's the best pain management for these kids. Okay. Once we've kind of focused on medical management and optimizing medical management, there are a few kids that would definitely respond better if we intervened with a procedure. So we can consider an ERCP if we're noting features of either obstructive jaundice or cholangitis. As they've been looking at it more recently in pediatrics, there's definitely similar technical and clinical success, as well as safety when we're looking at cases of peds versus adults. So it definitely should be something that you're thinking about, not hesitating if the patient meets the criteria. There's also consideration to do ERCP in cases of abdominal trauma, if you have, say, like a disconnected duct or fluid collections. So you should be thinking about this. If you are noticing your bilirubin is greater than 4, if you'd had obvious signs of either a dilated duct or a visible stone in the pancreatic duct on your first-line ultrasound, or if we're seeing kind of a persistent ALT greater than 3 times the upper limit of normal. All right. The other procedure that we usually think about is a cholecystectomy. So if a patient is presenting with mild biliary pancreatitis, this is definitely something to think about in their index admission. A study from 2017 was looking at incidence of cholecystectomy during that first admission or if it occurred later on. And they found that in the cases where cholecystectomy was deferred to later admissions, they actually found more recurrent hospitalizations for pancreatitis in the meantime, or recurrent admissions for abdominal pain. So they came down with a pretty strong recommendation to think about that in that first admission. Other management that's going to be really crucial is early feeding. And early in this sense is within the first 48 to 72 hours. And this should be thinking about any oral or enteral nutrition, as studies have shown that this decreases overall stay and may decrease the risk for organ dysfunction. If patients are able, you can certainly allow them to eat by mouth. If we're not progressing to good oral intake in those first few days, we would consider NG placement and enteral feedings. NJ is really only considered if they're failing oral and NG feeds. We don't necessarily need to bypass the pancreas. We really just need to get them nutrition. Specialized formulas are not required, so you can use any basic garden variety feed. And then in between episodes of acute pancreatitis, patients don't necessarily need a low-fat diet unless they have obvious signs of dyslipidemia or other concerns. From a 2016 study, Abu Al-Haja and her group were looking at fat intake during hospitalization for acute pancreatitis. As they were looking at this, they noted that higher fat intake was actually associated with lower daily pain scores. So we shouldn't necessarily be restricting our kids' fat intake while they're here in the hospital. And then they found no difference in pain scores between the different groups. So those that were restricted to clears versus a low-fat diet versus a regular diet, or those that were MPO. Okay, so now we've had one episode of pancreatitis. Where do we go from here? If you do have a patient that has had their first episode of pancreatitis and there's a compatible family history of genetic causes, you should definitely be testing them at this point. Otherwise, we kind of wait on that for the next episode. One thing we do know is that even after one episode of pancreatitis, patients may not have complete functional or morphologic recovery. So in this study, they were looking at a cohort of Indian patients with pancreatitis, and I will raise the caveat that this was a varying timeframes of follow-up, but they identified even up to 2/3 of their patients that had exocrine pancreatic insufficiency from about 1 month to even up to 12 months after. And there was also evidence of prediabetes in a much smaller segment of this population. So, we tend to write off one episode of pancreatitis and give kids a pass, but I think we should still be carefully watching these kids over time because they may be more likely to suffer from insufficiency, both from an endocrine and an exocrine standpoint. And even after one episode of acute pancreatitis, we do know that anywhere from 15 to about 1/3 of patients will progress to having acute recurrent pancreatitis. In a recent study published in this year, 2019, Sweeney and her group looked at a database of Cincinnati patients over a few years and found that 70% of those who had acute pancreatitis actually progressed to having acute recurrent pancreatitis, even within about 5 months. So it's a pretty short time frame. There's a subset that progressed a little bit more rapidly, and those were identified as patients more likely to be male, having a higher weight, or having a more severe case of pancreatitis the first go around with pancreatic necrosis. So how do we figure out if they have acute recurrent or chronic pancreatitis? Again, this is looking at our INSPIRE definitions. So now looking at the middle row, a diagnosis of acute recurrent pancreatitis requires at least 2 discrete episodes of acute pancreatitis and either a pain-free interval of greater than a month or a normalization of their lab values in between. To get someone to a chronic pancreatitis stage, we need just one of these following. So either we have abdominal pain that's consistent with pancreatic disease and imaging findings that look consistent with chronic pancreatitis, or imaging findings with exocrine insufficiency or imaging findings with endocrine insufficiency. So now if we've had recurrent episodes, a few additional things that we think of at this point. So if you didn't do it in your first pass around, you should be definitely getting advanced cross-sectional imaging at this point and doing an MRCP really to delineate anatomy and pancreatic response to things like secretin. If you're identifying obstructive factors on your MRCP, then moving on to ERCP, and this could be something that is a one-time process and done, but other people may need repeated ERCPs. And at this point, we should definitely be thinking about genetic testing. So a 2016 cohort of the INSPIRE group did identify that in acute pancreatitis cases, about 10% of those had an obvious genetic abnormality, but this progresses to about 50% in the cohort that develops acute recurrent pancreatitis, and is about 3/4 of the group that have chronic pancreatitis. As we're looking at the different genetic mutations that can occur, things like PRSS1 and SPINK1 were actually more likely to present with chronic pancreatitis. So these kids may not have classic signs of acute pancreatitis. They may have been misdiagnosed. Someone may have told them that they had constipation or gastro. And then when they do finally get diagnosed, at somewhere between 4 to 6 years of age, they're actually in chronic pancreatitis at this point. And another study in 2017 found that early onset pancreatitis was definitely associated with PRSS1 and CTRC. We don't tend to see a whole lot of CTRC in our population, but it is a genetic mutation that we should be keeping in mind. Okay. As we are looking at these kids that we've diagnosed with either acute recurrent or chronic pancreatitis, we definitely should be monitoring them, but how we do that is still a question. So the INSPIRE 2 cohort that I mentioned are being studied for disease progression over time. And currently they're doing yearly things like pancreatic elastase, fasting glucoses, A1C, and an oral glucose tolerance test to really get a sense of what that disease progression is and how we should be monitoring these kids better. After we've kind of thought about medical management, again, we think about procedural management. There are some kids with acute recurrent or even chronic pancreatitis where we haven't necessarily come to an identification of their risk factors. You could think about cholecystectomy and maybe thinking about, are we missing some microlithiasis that could be causing our issues? Or again, should we be thinking about ERCP? As we are thinking about ERCP, we're thinking about how we can intervene at a ductal level. So if there's stenosis or dilation that we need to help drain and open up, or do we have more of a stenotic papilla that we need to go and open up again to help with drainage? Or do we have a stone that's obstructing our duct, and removing that obstruction will remove inflammation and damage. I will say not a lot of pediatric gastroenterologists are trained in ERCP. This is a highly specialized field, and you do need to perform a certain number of them per year, so not a lot of us end up pursuing this advanced training. So we tend to rely on our adult colleagues to do this, but they are very confident, and especially here at our institution, they've done quite a number of them for us, and we're very pleased with their collaboration with our team. So as we're looking at progression further, we do know that those with acute recurrent pancreatitis can progress to chronic pancreatitis within even just 2 to 5 years. And so that's looking at anywhere from about 20 to 40%. It's definitely an increased risk if we're exposing ourselves to toxic environmental factors like smoking and alcohol. So it's definitely something we counsel our teenage patients about. I think all of you are probably familiar with the different genetic abnormalities that we can see in our kids with chronic pancreatitis. So just a few to mention. PRSS1 is an autosomal dominant disease. It does have variable penetrance, but it's fairly high. And you can see it can be anywhere from about 20 to 33% in different pediatric cohorts as they're looking at things. This is probably the most important one that we deal with. It is more of a gain of function mutation, and we get early activation of trypsin and then autodigestion of the pancreas. Over time, this was previously thought to lead to up to about 40% lifetime risk for pancreatic cancer. And so that's definitely something that people get monitored for over time. But there have been actually more recent studies that put that risk probably closer to about 7 to 10% based on the modeling. So it's maybe not as high of a risk as we previously thought. Okay. And then there's still significant disease burden in those with acute recurrent pancreatitis and chronic pancreatitis. And this was from a 2016 study published in JAMA Peds. And it's a busy slide, but a few things to highlight. So as we're looking at that middle column with acute recurrent pancreatitis, there's about 20% of this population that has any level of constant pain. And then as we're looking at the chronic pancreatitis, that can go up to about 26%. And then as we're looking at lifelong emergency department visits, I feel like these numbers probably underestimate what we see here, but it can be about 2 in the acute recurrent pancreatitis, but a broad range of 0 to 30, or about up to 4.5 in those with chronic pancreatitis. But again, you can see the range there is about 0 to 300. So you will be interfacing with patients and interfacing with them regularly. And then the other thing to think about is hospitalizations. So it's about 2 lifelong hospitalizations in acute recurrent pancreatitis, but still, again, that broad range of 0 to 30, and about 4 in chronic pancreatitis, but still, again, that broad range. And these patients have significant quality of life interruption. So we're missing days of school, we're missing the activities that we want to participate in, and it has a really significant impact kind of on their mental health and their physical health as well. So these estimates here were 0 and 2 for acute recurrent and chronic, but I think you see far greater than that usually in practice. Okay. So as we've been kind of highlighting before, the few modalities of intervention that we can use for management, and this is looking at both acute recurrent and chronic pancreatitis. So we think about medical management, whether this is treatment of endocrine or exocrine pancreatic insufficiency, it's pain medications, it's vitamins, it's things like that. And then again, endoscopic management if we need to dilate biliary duct stenosis or pancreatic duct stenosis, if we need to remove stones, or if we need to open up a stenotic papilla. And then we do think about surgical management. And that is, again, things like cholecystectomies. It's also any sort of drainage procedures of the pancreas. But it also is thinking about TPIT. So this is just a quick table from a 2016 article that looked at various managements between the acute recurrent pancreatitis group and the chronic pancreatitis group. And I've put some arrows just on a few. So starting at the top, these patients are 2.4 times more likely to be on any sort of chronic pain medication, 6 times as likely to be considering on any type of medical therapy, and about 5 times more likely to have exocrine insufficiency and be on pancreatic enzymes. If we're looking at endoscopic procedures, the chronic pancreatitis group is about 13 times more likely to need to undergo ERCP, and about 42 times more likely to undergo ERCP with stone removal. And then that very last arrow, chronic pancreatitis group is about 76 more times likely to undergo something like TPIT. And so now I'll hand it over to Dr. Bellin, and she's going to go through how we consider someone to be a candidate for TPIT.
So I'm going to start with a clinical case here, but I want to emphasize that the patients that we see for surgery, we don't start with surgery, obviously. So these patients, as Dr. Downs presented, they have recurrent acute pancreatitis, chronic pancreatitis that first is managed medically and, if appropriate, endoscopically. And as you saw, even in the INSPIRE cohort, which is probably enriched by our center enrolling, only about 20% of the patients, the children with chronic pancreatitis, go on to TPIT. So we're really talking about the most selective, most severely affected population of children with this disease. So just to give you a typical example of someone who would come to us for TPIT, now 95% of these patients come from out of state, only probably about 5% of our children come from this area, so it's very common for us to get this national referral base. This little gal, her mom, has given me permission to present her case. This is a pretty recent picture of her. She came to us actually initially when she was 3, but she had surgery when she was 4 years of age. She actually started having symptoms when she was about 1.5 years, but as often happens, as Dr. Downs was mentioning, it's not always thought of to test children for pancreatitis, and so especially in a 1-year-old. So she went for a while not being diagnosed properly, but at about 2 years of age was diagnosed with acute pancreatitis. That very quickly became evident that it was recurrent acute pancreatitis. She was actually really unusual. About 80% of our patients we see now for surgery have diagnosable genetic mutations that Dr. Downs was talking about causing disease. This little gal did not. She's considered idiopathic. She had an unusually enlarged pancreas. She was admitted to the hospital about 12 times for pancreatitis management, but she basically couldn't go about 2 weeks without having acute pancreatitis. So one episode would resolve, a couple weeks later another would start. So she was just constantly in and out of the doctor's office, hospitals, on pain medicines. There was some idea that she maybe had autoimmune pancreatitis because she had this large pancreas. That really didn't turn out being the case, but she had been treated in the past with prednisone, azathioprine to try to resolve the pancreatitis. So she kind of came to us with that background in mind. I think she had one trial of ERCP, although we really reserve ERCP these days for children who have a stricture or a duct stone or something obstructive to treat. She went on eventually to have TPIT in 2012. So now she is just coming up on 7 years out from her surgery. She has not been hospitalized. She's been completely pain-free. She was obviously using opioids before for pain management. Now she's been opioid-free. This gal has had some short periods of time where she was completely off insulin, but mostly she's been on some basal insulin, but with very well-controlled diabetes. So her A1C typically sits in the 6s. And she has obvious islet graft function, which we assess by looking at C-peptide. And so this is her at 10 years of age playing on the beach. And one of the things that I think is really remarkable about her case, she went to surgery very young. 2-3 years after surgery, they were back for a routine follow-up visit, and I'm asking routine questions about pain. And Mom says, well, no, she doesn't have any pain. She says, in fact, she doesn't really remember having pancreatitis or surgery. She asked us where the scar in her belly came from. So really remarkable tribute, I think, to the resilience of children. So the goal of a total pancreatectomy islet autotransplant, really we have to keep in mind that the primary goal of this procedure is to remove the pancreas in order to relieve the pain. So we think a lot about this fancy islet transplant part of the procedure, but really the primary goal is pain relief and restoring quality of life for these patients who are really severely affected with disease, who are missing school, who can't do usual childhood activities. And the islet autotransplant is a secondary goal. So whenever possible, we want to be able to induce remission of post-surgical diabetes, or at least minimize the burden of that diabetes by giving back some of the islets, infusing them into the liver in order to maintain some endogenous islet function, some insulin production. So this is a really major surgery, obviously. And I tell the patients who come in that pancreatectomy is complicated, not just because they're getting the pancreas out, but the way the pancreas is anatomically situated. The pancreas shares blood supply with the small intestine, with the spleen. And so when they have a pancreatectomy, it is a pancreatectomy, a splenectomy, a duodenectomy. The gallbladder comes out if it hasn't been resected. And then basically I tell them the plumbing has to get put back together. So they have a Roux-en-Y anatomy of their gut and a cholecystectomy. So it is a pretty big deal, obviously, and this is why we reserve it for the most severe cases. The patients also have a feeding tube that's placed, so anyone who's managed these patients in hospital is familiar with that. That's because of the Roux-en-Y procedure and the gastroparesis that occurs for a few weeks after surgery. So we use a jejunal feeding tube in order to get proper nutrition for surgical recovery. Meanwhile, when the pancreas is resected, we have a team that is just an islet isolation or islet manufacturing team. So their day in and day out job is actually to work with pancreases to extract islets, and they actually physically come and take the pancreas out of the operating room to a different facility that's set up for islet isolation. They process the pancreas using a collagenase enzyme and a special mechanical digestion chamber to isolate those islets, and they basically send the islets back to the operating room, kind of like a medication. They're in a medication bag. The very final portion of the surgical procedure is actually pretty brief, infusing the islets. So the patient is still in the operating room with an open abdomen, and the surgeon will put the IV into the portal vein, or usually the splenic vein tribute into the portal vein, and the islets will just drip in under gravity. So they just follow the blood flow into the liver portal vein branches off into the sinusoids. The sinusoids are small enough that the islets become wedged in the liver. So the transplant process itself is actually fairly simple, but there is a risk when we're putting these cells into the vascular system that the body basically wants to form a clot, so there's a risk of portal vein thrombosis. So there's heparin in with the islets, and the patients are heparinized. So these are some pictures from our islet processing lab. And so the very first thing they do when they get the pancreas back is they inject collagenase through the pancreatic duct. So incidentally, this is one of the reasons why we really don't like to do Pusto or classic drainage procedures on these children anymore with genetic disease, because we know that they're very likely to relapse and need a second surgery at some point, and we can't isolate islets very well when they don't have a pancreatic duct anymore because it's been opened by surgery. And then you can see the subsequent steps here. This is a Ricordi chamber, so it's kind of the mechanical digestion chamber, and this figure that's in the lower middle is the islet stained red and kind of some surrounding exocrine tissue. That's typically what an islet graft would look like that we're bringing back to the OR. So we infuse these islets into the liver, mainly because that's the place that was best established to work in large animal models back in the 1970s. So this program's actually been running with clinical patients since 1977. And it's still considered the best spot that we have, but it does have some limitations. So one of them is that when we infuse those islets directly into the bloodstream, it does trigger that inflammation and procoagulation response. So people will call that the instant blood-mediated inflammatory response, and so that can be damaging to the islets themselves. No matter where we put the islets, they are devascularized, because by the islet isolation process, all the small vessels that supply blood and oxygen to the beta cells is disrupted. So they are in a very hypoxic environment early on, but they really do this remarkable thing that the islets will produce things like vascular endothelial growth factor, and that will stimulate revascularization. So they do revascularize over time, but during that period of hypoxia, they're very prone to islet loss, to beta cell apoptosis. That is why we really target very tight glycemic control in these patients that are in the hospital, because if we're stimulating the beta cells to try to produce insulin in a hypoxic environment, we know that can be damaging. They are deinnervated, so we don't know what the functional consequence of that is. They're potentially exposed to kind of portal toxins. This is most relevant if you've, say, had someone on immunosuppression for a islet transplant for type 1 diabetes. But they are self-regulated units, beta cells, so they maintain glucose-responsive insulin secretion. The alpha cells may not quite work normally. It seems that there's a liver-specific deficit in the alpha cell response to hypoglycemia, possibly because the alpha cells are so close to the glycogen liver stores that they just don't see the hypoglycemia very well. We do basically the same surgical procedure in kids and adults, but the children are not just small adults, obviously, so there are some unique considerations for our pediatric population. They are a little bit unique to start with because they're mainly genetic disease, as opposed to our adults, which are about 10 to 15% genetic disease. Obviously, they still have to go, they're still growing, they still have to go through pubertal development, they're attending school, so they have some unique considerations there. And there are some technical challenges in the children, both to the pancreas and the surgery itself. So even though we have some of these young kids who are 3 or 4 years of age, our surgeon likes them to be to a certain size and have a certain liver volume just to physically make the surgery possible, so he's not working with such small anatomy. And the isolation team will tell us that the islets that the children have, the very young children have, tend to be more embedded in the exocrine tissue, so it's a little bit more difficult to separate those islets from the exocrine tissue, so they've developed some very special protocols that they call young donor protocols to actually perform isolation a little bit differently in our youngest patients. And we see actually some very unique outcomes in our prepubertal, our youngest children. They do really well with pain control, the youngest children, once they recover from surgery. They often tend to be completely pain-free, as opposed to some of our teenagers who may have some chronic residual abdominal pain, and they also do really well from a diabetes standpoint. So this is a really big team of people that's involved in taking care of these patients who get to this point of having TPIAT. Obviously, we need surgeons and gastroenterologists and endocrinologists and endocrinology diabetes educator team and pain physicians, but we also have a lot of supportive ancillary care providers, including psychologists, physical therapists, dietitians, child life. Every patient has a nurse coordinator who integrates all the management among the different providers providers, and the patient and family themselves are actually a really important part of the recovery process, as is the local primary care provider who's going to have to help with long-term management of this patient. But one of the things we really try to highlight, and Dr. Armfield, our pain doctor, and Molly are just great at highlighting the role of the patient and the family and getting ready for surgery and kind of prehabbing someone for surgery and getting them in the right physical and emotional health. So who do we consider actually a candidate for TPIT? Well, it depends a little bit on the goals of the family and the child too, but obviously our very first top question is we want to make sure that the pain, the debilitating pain that they are having is actually from pancreatitis. So that tends to actually be straightforward in a lot of our children. Sometimes it's not in the adults, and once in a while it's not in children, but we want to make sure that they actually do have chronic and or recurrent acute pancreatitis, and many of our patients have actually both of these diagnoses. That is refractory to appropriate medical and endoscopic interventions. So they don't just, they have to have the right disease, and they don't just come to surgery first. They have to be debilitated enough. So we would actually prefer that our patients we see are not narcotic dependent, but some of them are. All of them are using narcotics for flares of disease, and all of them have significantly impaired quality of life. They're missing school, they can't do usual activities, families can't plan to take vacation, that kind of stuff. So we're looking also that they're otherwise healthy, that any psychosocial comorbidities are managed, ideally non-diabetic. Once in a while we have a C-peptide positive diabetic patient who comes through and has the surgery, so we're still trying to just save what they have. But everyone has a risk of diabetes. Everyone has to manage diabetes for some time after the surgery because everyone's put on insulin after the surgery, so they have to be willing to accept diabetes as a trade-off for pain relief. And the majority of these patients, especially the ones who have easy to control diabetes, will say that there's just no question that's an easier disease to live with than pancreatitis was. So because it's such a major surgery, and because it does have risks of complications as a major surgery, we do have to reserve it for the most severe cases. So we worry about diabetes, we worry about sensitization or neuropathic pain, which I won't get into too much. Worry about GI complications. The exocrine insufficiency has to be managed lifelong, so there could be micronutrient deficiencies. We have to do vaccines, manage them for asplenia. So there's a lot of things to consider in the picture. We manage them in the hospital early on with tight blood glucose control, as I managed. Pain management is a really important part of the recovery process. We have to consider these nutritional variables, adding appropriate pancreatic enzymes as they start eating, and the splenectomy precautions. So we have a really active research program at the University of Minnesota. We're actually the largest center in the world who performs this procedure, and we have the longest continually running islet lab in the world. And so there is some early research done in the 1990s around the islet transplant procedure here that was very well done, but there were still small groups of patients at that time, and the volume really started to grow here around 2005, 2006, as this procedure really became more clinically accepted. And so we've built upon our big volume here to have a number of different studies, both clinical trials and observational studies, including an observational study that has enrolled nearly every patient who's had surgery here since September of 2006 to help get long-term outcomes. So I'm just going to talk a couple minutes about the outcomes after this procedure, and it is mainly from this research that we've done here. So we look at health-related quality of life by an instrument called the SF-36. It's not pancreas-specific, it's just a general quality of life. What we see on average is that these patients, as you might expect, have very low quality of life scores compared to the population norm. If you look across the board, they improve by about 1 standard deviation score on average, which is a pretty clinically significant improvement, and the greatest improvements are around bodily pain and physical function, as you might expect. And I will show you that the improvements tend to be greater in children than adults. 85% if you just ask them perceived improvement, do you think your pain, your health is better now than before surgery? 85% will say yes. One of the challenges we have is 15% say they have a similar pain burden. That probably sits around 10%, I would say, in the children, but 15% overall. And for children, about 80% or more, 80 to 85% are really consistently off long-term narcotics, but we still have some that struggle with some chronic pain issues and going on and off narcotics. So we're doing a lot of work in trying to address that area of non-ideal surgical outcomes. So we look at the quality of life scores here with the circles that are pinkish in color being children and the gray squares being adults. We see that there is a significant improvement from the baseline, which is times 0 on this graph in both groups, but that is a pretty dramatic difference in the kids versus adults. And I think that reflects that the adults come in all kinds of different states of health with a lot of psychological burden and other comorbidities that make them a bit of a more mixed group than some of our children. If we look very specifically at children things, like does your child's health interfere with school attendance, how limited is your child, we see a very dramatic reduction from before surgery to 2 years after, 1 and 2 years after surgery, and limitation from health issues. But where do we have those patients where we fail to improve pain? Well, if you look overall, this is kind of grouping adult and pediatric data together. Patients who are on prolonged durations of narcotic exposure. They have both the long exposure to chronic pain and the long exposure to narcotics, which can mess up the central nervous system and cause problems. Patients who have had more ERCPs and stents, that might be more of a marker of kind of prolonged disease than anything else. Patients who have pancreas divisum, and I think that's not because divisum per se has a bad outcome, but that sometimes patients with divisum and abdominal pain start getting, especially in the adult world, ERCP and stenting, and then they develop an iatrogenic chronic pancreatitis, but it probably wasn't the original cause of the abdominal pain. And prior Whipple probably falls into that same category. So how do we do with the diabetes remission if you're seeing one of these patients? Well, it really depends on how many islets we're able to transplant. And so if we had like a donor islet transplant for type 1 diabetes, we would always give more than 5,000 islet equivalents per kilogram body weight. So islet equivalents is kind of our way of standardizing islet mass. We get that amount in about 35 to 40% of our auto transplant cases because they have such damaged pancreases. But when we do, and that's the orange bars there, when we do, there's a very high chance for complete insulin independence. About 65% or so of those patients on average are off insulin. Depends a little bit on the time point you're looking at. If you go to someone who has a more moderate islet mass, 2,500 to 5,000, well, they're almost always C-peptide positive, but they're only able to come completely off insulin in about a quarter of those cases. And then if you go to a low islet yield, less than 2,500, you only get about 10% insulin independence. So it really depends on how many islets we put in. But I do want to emphasize, without having a lot of time to get into all the data, that even the patients who are on insulin, the majority of them actually have their own endogenous insulin production. They have some functioning islets, just not enough to be off insulin. And that's hugely valuable because our body is actually better at self-regulating blood glucose control than we are with dosing insulin analogs or even by insulin pump therapy. And so we can get better control in someone if they have some endogenous islet function. So we'll call that situation partial islet graft function, where they do some themselves and we add some insulin on top. So what's the likelihood of a patient being insulin independent, and particularly for a child? Well, again, we see this relationship between total islet equivalents transplanted and the odds of insulin independence going up. But I also want to highlight, again, bringing back to these surgeries that we don't really usually do anymore on children, but we see some teenagers who maybe had a Pusto or a Fry, a drainage procedure, surgical drainage done as a child. When those kids come to us, their odds of actually becoming insulin independent are significantly reduced. They're very unlikely to come off insulin, actually. So what do we see in terms of insulin independence rates in children versus adults? Well, children have a little bit of a higher chance overall than adults at being off insulin after surgery, but that is really driven by the youngest kids. So the teenagers are actually pretty close in outcomes to adult patients, but these young kids who are aged about 3 to 10 years have much higher rates of insulin independence than our older kids, our teens and our adults, and that may be driven by a really favorable environment for transplant because these kids have pretty low insulin needs, they're very insulin sensitive. It may be that there's something more resilient about these beta cells we're transplanting. There are autopsy studies in children, not with chronic pancreatitis, just other children that really show a capacity for beta cell regeneration at this age. So the glycemic control overall ends up being similar. So these patients, young kids, aren't inappropriately off insulin. They have a very normal A1C off insulin. So, but we see overall that teens maybe have a little bit of a higher A1C on average. We have some of the same compliance issues long-term in our teenagers as we see in our type 1 diabetes population and any other population. So I think that impacts the glycemic control a bit in that population. One of the situations that we have here is we see a lot of PRSS1 disease. That was the autosomal dominant trypsinogen mutation. And so we've been able to use that to say, okay, what is the effective duration of disease? And there is, as we would expect, an islet loss over time as you have more years of disease. It's relatively slow, but we see about 22% loss of islet mass for every 5 years disease duration. But this group of hereditary pancreatitis, even when you include the adults who have more mixed outcomes, do really well in terms of being off opioids. 85% of all of them, including the adults, are completely off opioids. So I just want to acknowledge that we have this very large multidisciplinary team. I don't think everyone's even in this picture, so there are a lot of people who collaborate both on the pediatric and adult program and some of the research team that helped bring some of the data that I was presenting here, and then Elissa and I will take any questions.
Great, thank you very much. Your last slide, or second to last slide, caught my attention when you were talking about the teens and the A1C, and it looked like you had up there an average of 7 in the range.
About 7% for the teens.
Mm-hmm. So that actually...
It's much better than type 1 diabetes. Okay. So, right. So I have another slide that compares kind of A1C to the type 1 diabetes exchange children. And we have, although we have a range and we have some who are very poorly controlled, because we get that endogenous islet function, some are off insulin, some run A1Cs in the 5s, even though they use a little bit of insulin. We have a much better average A1C if you were to compare to a type 1 diabetes registry. Absolutely.
Okay, terrific. Thanks. I just wanted to make sure that...
that's correct.
We recognize that they're actually doing pretty well.
They're doing pretty good, yeah.
So nice talk first, from both of you, thank you. But is there a way of expanding the islet cell or the beta cell population? Is there any work going on in identifying a, inducible stem cell that could differentiate to increase that likelihood of insulin independence?
Yeah, so there have been features that we've looked at before surgery, both to try to predict just the number of islets there, and features that others have looked at to maybe predict are there factors that go into islet regeneration, say after transplant. So we have some correlates with our metabolic tests that roughly predict islet mass on the population level. In terms of islet precursors, there was some work that came out of the United Kingdom that suggested that if you had more pancreatic ductal cell markers, CK19 and such, that you had better outcomes actually after surgery, even when adjusted for the islet mass transplanted, so that perhaps, and we've seen on some of our pathology studies that some of these patients with chronic pancreatitis are exhibiting islet neogenesis from ductal cells, so that perhaps there are some precursors that we transplant there. What we really don't have is we just don't have histology after we transplant these cells. They disperse through the liver, so it's not easy to do a biopsy. So then it's hard for us to go back, and there's no imaging way to see islets, so it's hard for us to go in after transplant and directly look at the islets.
I'm curious, in addition to the auto islet transplant for these patients that end up still being either dependent on insulin or are outright diabetic after this procedure, is your research group thinking about, in the next few years or decade, either with some of the pseudo-islet work in Cincinnati or other groups that are trying to go more of the stem cell route, supplement the auto islets in immunoprivileged sites?
Well, yeah, or this would actually be an ideal group for autologous stem cell generated islets, right? Because they don't have the autoimmunity of type 1 diabetes. And we don't have, we have some stem cell type 1 diabetes studies going on right now, but we don't have any of the autologous work, autologous stem cell derived islet work going on here yet. But I think this would be a really good population for that. The place where we've actually done transplants is a few of the adults have had whole organ pancreas transplants. And they've done well with that, but that obviously carries all the surgical and immunosuppression risks of a whole organ transplant. So.
Dr. Downs, I was just wondering, very brief here, but on the slide at the beginning when you were talking about the incidence of hospitalization, you were saying that it was like 6.2 to 7 per 100,000. Is that 100,000 of general population or 100,000 like admissions?
So it's looking at like the general population and more specifically like the pediatric population overall. So it's still a pretty high number.
All right, time is up, but really quick.
I think so. It's a logistical question. You guys mentioned that you have your adult colleagues help out and participate with ERCP. What's the smallest by mass maybe or youngest kiddos that we're able to do that for here or kind of in the area?
So I think, you're a little bit limited in sometimes the size of the equipment because the ERC equipment is a little bit larger than, say, our standard scope. But our adult interventional endoscopists can be as comfortable as doing ERCP in kids as young as 3 or 4. So ideally, there's probably a target body size, but sometimes it's just sort of an age cutoff instead. So yeah, Sarah Jane was saying that if we can get the smaller equipment, we can certainly do younger children. It's just not usually universally available. Yeah.
All right. Thank you very much.
Thank you.
All right, go for your question.
Right? Yes.
You have been disconnected from the meeting.